supporting the respiratory system by mechanical ventilation. So if we look at it a little differently, we have a progressive loss of essentially two primary functions of the lungs. One is getting air out with mucus, so airway clearance, and the other is ventilating, removing carbon dioxide. And this is a cartoon that I just drew talking about how they both have a rate of decline. We look at airway clearance in terms of the flow you can generate during a cough or a peak cough flow. And we look at ventilation based on how much carbon dioxide is in the air that you're exhaling. And if it's a high amount, it means that you're not really ventilating fully. In other words, not washing out the carbon dioxide your body produces. They're sort of normal ranges, and we start with a peak cough flow that's somewhere about 500 liters per minute, and then some feel that when you get down to about 270, you start to get into a phase where you need to worry about airway clearance, especially during an acute illness. Then when you get down to about 160, the feeling is that if you're below that, you're going to have lots of trouble coughing effectively. Whereas with your carbon dioxide, at some point you start to, this actually doesn't represent it properly, actually the carbon dioxide starts to rise, and when you get up to the upper limit of normal of 45 millimeters of mercury, you then get into a stage where you're not washing out the carbon dioxide properly. Then we get really concerned when it gets above 50, and that's usually when we start to initiate ventilation. And so if you look at this, there's sort of a danger zone that we worry about here. And where it becomes a little tricky is if you have an acute illness or you're going to do something that acutely can alter the respiratory system, such as undergoing anesthesia. And what can happen is you can be in a perfectly normal position with airway clearance. During an acute illness, you may drop into the red zone where you're going to have problems. And the same can certainly apply with ventilation, where you might be ventilating perfectly well on sleep study, but then during an acute illness or after anesthesia, you can drop into a dangerous position. And so if we think of another way of looking at this is when we breathe at rest, we start at our resting lung volume or functional residual capacity. They breathe nicely through tidal range. And then we start with having additional volume we can recruit called forced vital capacity, which is taking a deep breath and then breathing out as long and as hard as you can. And typically that's about 10 times your tidal volume. But what happens over time is as you lose function, that vital capacity declines. Then if you get to a position like this right here, and then either have an acute illness or undergo surgery, in the postoperative period or in the acute period, that vital capacity, that volume may drop below your tidal volume, which means it's dropping below the point that allows you to breathe effectively. And this, dropping into this situation would make it very difficult to be able to be extubated successfully on the first try or to be able to get through an acute illness efficiently. And so there are ways to mitigate this risk, and we'll start to talk about those right now. And the first is airway clearance. And before talking about how to fix it, it's important to know what's involved in coughing. And there are really three distinct phases. The first is you take a big deep breath, you fill your lungs. As the lungs get more full of air, the airways dilate, allows you to get mucus air behind where mucus is in the airways. And then you do two things in rapid succession. One, you start to exhale very forcefully, and you close your glottis, you close your vocal cords for about a quarter of a second. Then when they open up, after the pressure is built up, you get an explosive exhalation that carries mucus and any other debris out of the lungs. And so if you're deficient in either breathing in, controlling your vocal cords, or having forceful exhalation, you're going to have abnormal airway clearance. So if we talk about how we can compensate, the first is you can certainly help by breathing in, you can help by breathing out, and you can do both of those together. And then I'm going to finish by talking about a couple of other ways of helping with airway clearance. So for inspiratory assistance, there are a variety of different things that you can use. Over here on the left is a non-mechanical device that allows you to do what we call breath stacking. And this is a simple resuscitation mask with a little Y piece here, with a circuit that has a one-way valve that allows you to breathe in. Then you breathe out against a resistance, and then there's an exhalation port. And when you close the exhalation port, you can breathe in, but you can't breathe out. And what you can do is to slowly keep breathing in until you can't breathe in any deeply. So you do what we call breath stacking. And then after that, you remove the mask or remove your thumb from the exhalation port, and the patient can breathe out as forcefully as they're able to. Mechanically, you can use something called the cough assist. You can set it just to give an inspiratory effort and not an expiratory effort. And there's a device that's used very commonly in France and in Europe called the Alpha 100 or Alpha 200. I think there's an Alpha 300 now that just gives you a positive pressure to help you take a deep breath. To help with exhalation, mechanically you can actually do either chest wall compression, so this is at rest, and then this is pushing on the chest wall to help with exhalation. Or you can push on both the chest wall and the abdomen at the same time. This is often done coincident with, right after breath stacking. So without a mechanical device, you can do breath stacking and then shift over to a manually assisted cough. It's obviously very effort dependent for the care provider, but it is something that you can certainly do. I think the more common approach is to use the cough assist or the mechanical inexiflator, which again is this device. And what's done is that you set an inspiratory pressure, usually with a brief pause, and then an expiratory pressure. And there's no prescriptive way of doing this. It's purely based on patient tolerance, often needing to start with pressures perhaps below therapy and then increasing to what a patient can tolerate. Many patients end up between about 30 and 40 centimeters of water. Some need to start between 10 and 20 until they're comfortable with the sensation of having a deep inspiration. The next issue comes with how frequently you do a cough assist. And when I'm asked that, I often say, well, how often do you cough when you're sick? And the answer is you cough as much as we darn well need to. And so for you as parents, you can certainly use that more freestyle approach, but for patients that have nursing, then we have to come up with something that has sort of a baseline 2 to 4 times a day approach with additional treatments as needed. Then I want to move on to talking about mucus mobilization. There's some other accessory ways of doing airway clearance. And these all require an intact cough or require something like the cough assist or the Alpha 200 to help with airway clearance. The first is this thing called Intrapulmonary Percussive Ventilation, or IPV. This is the home version. What it is, it has a pressure oscillating generator and then a nebulizer. This part connects to the patient, and it applies nebulized medicine, usually saline, under pressure with vibration. The 3 of those things together can be helpful in mobilizing and freeing up mucus peripherally, but still requires another way of coughing and helping to remove mucus from the more central airways. Another form of this is something called high-frequency chest wall oscillation, or more simply, the vest. This is very common in cystic fibrosis, and pretty much every patient with cystic fibrosis has a device like this. And what it is there's a jacket right here that has an inflatable air bladder, and then another pressure generator, an oscillating pressure generator that fills the jacket, and then it oscillates pressure at very high frequency. And it's been shown to be very helpful in mobilizing mucus peripherally, but still, as I mentioned, requires an intact cough. So as a single mode of therapy, neither IPV or vest is suitable in neuromuscular disease, but can be helpful as an accessory therapy. Then I just want to touch very briefly on, there's some pharmacotherapy that, again, is very common in CF, but can be applied in non-CF patients, such as patients with neuromuscular disease, often acutely in the hospital. The first is something called Pulmonary, or Dornase alpha. It's an enzyme that breaks up DNA, which is part of the nuclear contents, and when a patient has an infection and you get white blood cells or pus in the lungs, leaves a lot of debris, and that debris is broken up very nicely by pulmozyme. There's absolutely no evidence and no reason to feel that it might be helpful chronically, but it may be helpful acutely. Hypertonic saline is concentrated saline, usually 3 or 7% compared to the 0.9% that's in a standard nebulizer. And it's also helpful in hydrating mucus. It's been shown to be helpful in cystic fibrosis, and acutely it can be helpful. Some people feel very strongly that it can be helpful chronically. However, the only problem with that is that it hydrates normal mucus and thick mucus. And so if you're using it initially when you have very thick mucus, and then the mucus isn't thick anymore, you're going to continue to hydrate, and then you can get into the other situation of having too many secretions. So using it requires somewhat of a delicate touch. Then the other thing, if you have too many secretions, is looking at the possibility of hypersalivation, using an anticholinergic medicine like Cuposa or glycopyrrolate can be helpful. Sometimes it's just, boy, you just have allergic rhinitis, and antihistamine can be helpful. And if you're lying down a lot, you're at risk of having reflux, and so sometimes the anti-acid therapy can be very helpful. And so I think I'll finish by talking about just a general preoperative plan, and getting back to the first slide, I think it's important to have a plan for airway clearance and really lung recruitment. Airway clearance for an acute illness, lung recruitment for recovering after anesthesia. And that really requires doing some thinking beforehand, and if your child's not on a cough assist, then perhaps talking about having one available postoperatively, and that would require going to pulmonary office visit and having a therapist help titrate to a proper pressure. And then whether or not you need non-invasive ventilation is kind of where you are in the disease. If you're fairly close to the upper limit of normal in terms of carbon dioxide, then it might make sense to have a non-invasive ventilator available to transition from invasive ventilation. And the final thing, if all else fails, I encourage you all to be a difficult parent. And really what I mean by that is being a strong advocate. And I think sometimes we get very set in our ways, and we're always certain but not always right. And you guys are really the experts in your child's condition. And I think you can serve a really valuable role of being an educator for those of us that have a pretty good sense of what to do, but certainly aren't experts. So I think with that, I'm going to turn this over to Hemant, and he's going to talk about ventilation.
That's in exhalation, sorry. Thank you. So I guess one of the advantages, I never saw myself doing this full time, working with almost, I think the field of pediatric pulmonary neuromuscular medicine seems to really be evolving almost as a specialty by itself. And one of the blessings I have on my end is, one is the institutional support to support this effort almost unequivocally, that, okay, this is what you do, you enjoy it, have fun, but also the fact that having some amount of sleep training, sleep medicine training, really I felt added the finishing touches to being able to provide a little more depth of care. So, what I want to talk to you about is go through a little bit of just the basics of how we breathe and what we breathe and why hypoventilation occurs, and a few definitions, and then to springboard into some of the night times, into some of the support mechanisms we have for that. So very briefly, we are blessed with a bunch of ribs and a bunch of backbones, and they would really all be very useless if they didn't articulate into a very flexible and pliable shell. And the job of the chest wall is really not only to protect your lung and heart from bumping into something else, but it's also to optimize breathing efficiently and support our form appropriately. With good form comes good function. It's just kind of a dictum. So what happens when we breathe? When we breathe, we tend to have a three-dimensional excursion of the chest wall. So you don't realize it, but over here, when you sit down and you breathe, 500 mils of air, and you don't even wrinkle your shirt. That's because you're experiencing a three-dimensional change in all measurements of the chest wall. There's an increase in the front to back dimensions by an upward and outward movement of the sternum. The rib cage also moves in a left to right manner, and that increases the left to right dimensions or the transverse dimensions across the chest. The third dimension is a downward or southward movement of your diaphragm, which also leads to a vertical increase in measurements. So all these three changes lead to a rather uniform expansion of the chest wall with efficient displacement when you are upright. So what happens when you lay down? Well, when you're upright, diaphragmatic excursion tends to be rather unencumbered. Gravity acts in your favor, bowel contents fall off the diaphragm, and so the diaphragmatic excursion becomes much more unimpeded. And that optimizes the degree and depth to which you can breathe in and out. So what happens when you lay down is gravity still continues to act in a downward manner. But if you have an element of diaphragmatic weakness, the bowel contents are not going to push further down because there is a backbone, or you've got a pelvis on the south end of you. So the bowel contents are really going to move or displace the diaphragm a little higher, and that means it's going to move up into the thoracic cavity. So the problem with that is that some of this occurs with all of us, and the average change in lung capacity ranges from 5 to 20%, and this is largely extrapolated from adult data. So if we see a change in vital capacity of greater than 25%, we have to, when moving from a vertical to a recumbent position, we have to think about diaphragmatic weakness. So for some of the CMDs, this is a much more significant issue to deal with. When this happens, it's going to lead to a reduction in how deeply someone can breathe, what we call the tidal volume. So what is the importance of having an optimal tidal volume? Well, if you think about that 500 mils of air that you just had to breathe in and breathe out, 150 of that is still running from your nostril down to the pathway due to conducting airways, which means the airways that do not participate in actual gas exchange. So what that is called is dead space. The remaining goes to the smaller units of the lung called the alveoli, where actual gas exchange occurs. So it's almost like, think, you walk down into the mall. Before you get to the store that you're interested in, you have to go through hallways, right? So the hallways is dead space. Your business end is finally in the store. So it's important that the optimal depth of respiration remain so that we can get air out all the way to the periphery of the lung. What happens if you start breathing shallower? Well, very simply and schematically, if this 500 mils was to drop to about 250, the dead space would still take its pound of flesh, which means you would have a much smaller amount available to go out to the periphery of the lung. So even though you had a 50% reduction in how deeply you were able to breathe, the effective reduction at the furthest recesses of the lung is closer to 70%, right? So if you were to try and inflate a balloon, it's a lot harder to start. But at the optimal volume of air, it suddenly becomes really easy to add more air to the balloon. And that is largely because you hit that sweet spot of volume in the balloon where adding more air becomes easy. So the same is true for the lung. that at optimal lung volumes, it becomes really easy to breathe. But if your lung volumes keep dropping, then it becomes an issue, which takes us to this whole definition of respiratory insufficiency. There are lots of words that you hear throughout the course of the evolution of any of the muscular dystrophies. And so very loosely, things that get thrown out are respiratory muscle weakness, respiratory failure, cough impairment, hypoventilation or hypocarbia. All of these are all come under the umbrella of a waste paper basket term, I'd say, called respiratory insufficiency. So weakness of the respiratory muscles, like Dr. Mayer has already explained, will certainly lead to predisposition to eventual respiratory hypoventilation, cough impairment, like he spoke about, and then respiratory failure, which Dr. Graham will talk to us a little bit about. So when we look at hypoventilation and hypercarbia, as we say, what they really mean is hypo means less, ventilation is actual gas exchange. So I like to explain that when we breathe, we do two things. You breathe in, you oxygenate. When you breathe out, you ventilate. You get rid of the stale air. It's what you would do when you go home and you air out the house. You're ventilating the house. You're getting rid of stale air. So hypercarbia is a term that's also used to describe an actual increase in measurement of the carbon dioxide level. So collectively, there is this feedback process that kicks in. I feel there's a magical threshold for every individual, wherein if you breathe, with the right degree of muscle weakness, it certainly leads to changes in respiratory mechanics. What's interesting is the degree of chest wall rigidity that comes into play with congenital muscular dystrophies. And the other aspect of the chest wall that also gets contributed to become more rigid is certainly spinal curvatures. Sometimes the diaphragmatic dysfunction can simply be because of significant torquing of the diaphragm because of the degree of curvature. And the diaphragm is supposed to maintain a certain optimal geography, but the moment we have a vertebral shift, scoliosis is about changing the orientation of vertebral bodies, it'll also drag ribs along, and so your diaphragm, instead of maintaining an optimal position, gets torqued and becomes harder to excurse through his entire range. So how do we subject these individuals to tests to measure this a little more elegantly? We call it the sleep study, but parents digress and call it the sleep less study. So there's a number of electrodes that get hooked onto the individuals. And we measure there's about 18 channels that we measure. These are the typical electrodes. There's a special glue. So often when children come for the studies, we'll ask them, make sure you have your hair washed so that, especially boys who tend to use funky gels, it can otherwise really create issues with conductivity of, as we try to read the electrical signals. We encourage people to bring their favorite dolls and their blankets or whatever helps put them to sleep more comfortably. And it's not a painful test, but certainly for the people who watch overnight, this is a small photograph of the control room where we acquire everything on various terminals. That's a typical representation of what occurs in the study, and I'll show you a little more. That's a comfortable patient bed, but that's the uncomfortable parent bed. By design, unfortunately, at Cincinnati, this is right underneath a cold air vent. So the child is often hot, but the family is always cold. So we always have a microphone over the airway, over the trachea, so we can pick up snoring or any other sounds. There's some EMG, electromyogram, leads to look at muscle activity in the chin. There is stuff on each side of the eyes to look at eye movement so we can pick up dream sleep. And of course, there's a bunch of stuff in the hair which the girls dread when they have to wash out next morning. So this is kind of what we have to look at when we get the studies and then generate about anywhere from a 5 to 12-page report and then interpret that. So what you're seeing over here is someone who's asleep. It says supine position. That's the epoch number. That's each of these. This is a 30-second and a 30-second slot. So it's a 1-minute screen, and this is dream sleep and REM sleep, and you can see some rapid eye movements. Trust me, it's there. These almost looks like sharp blinks, and that's typically where we would see issues occur during sleep. And in this particular case, we always measure carbon dioxide levels in all our studies. And so, as Dr. Mayer was saying, you have to be a good advocate. It's important to know that when your child is being subject to a sleep study, make sure that they're going to measure carbon dioxide levels. We also measure the carbon dioxide level across the skin, or what we call transcutaneous capnometry. Trans is across, cutaneous is skin. And the reason is because we like to see good corroboration between the skin and the breathing sensors. And there's a bunch of airflow channels that we look at that are triggered by the temperature of air. Remember, cooler air is inhaled, warmer air is exhaled. So we can pick up real subtle drops in airflow. At the same time, it also measures pressure. It's triggered by pressure. And then, of course, there's chest and abdominal wall excursion, and we look and see, are the chest and belly moving appropriately, or are they even moving out of sync? Those are all subtle indications of some respiratory instability. So there's a lot that goes into this. So now, not only should you be inquiring into the sleep lab as to what kind of studies they do, and do they use carbon dioxide levels, carbon dioxide assessment techniques, but also to note that they do measure or do manage individuals with muscle weakness, whether it's ALS, Lou Gehrig's, Duchenne's, SMAs. And the reason is because, I'd like to say this as politely as possible, not everybody can interpret sleep studies in the most appropriate manner. And knowing the diagnosis of the individual being subject to a sleep study is really important in the appropriate interpretation. There are a number of sleep labs run through the country. Now you can get sleep labs run by dentists, ENTs, psychiatrists, neurologists, and pulmonologists, and family practice. Perhaps maybe in internal medicine. I don't know if, sorry? Yes, I said, and psychiatry, I said. So it's really important that you also know who is going to be interpreting the sleep study, because at the end of the day, we just get a sheet of paper that our families bring in that say this is the sleep study report, and often there's data missing from that we would really like to see, knowing, bless you, knowing exactly what the diagnosis is. So what is hypoventilation? And that is yet to be defined. For the purposes of, a lot of the definitions in pediatric sleep medicine have all been extrapolated from what the adults have taught us or tried to teach us. And unfortunately, adults like to teach the pediatric groups, but they never like to learn from the pediatric groups. So nocturnal hypoxemia was defined as saturations less than 90% for greater than 2% of the time at night. And these was definitions used in some of the studies that included Duchenne patients or different neuromuscular disorder patients. Hypercapnia, or elevations in carbon dioxide, was defined as capnometry, and this is transcutaneous, greater than 50 millimeters of mercury for more than 2% of the time at night. So you can see that there are variations. Some people use saturations, and some people use transcutaneous. And there's also another definition of end-tidal, which says if it's more than 50 millimeters of mercury for more than 25% of the time at night. So there are a variety of definitions that are in play for this. Why would we be considering initiation of support? Well, very often the symptoms that people will present with are fatigue, largely because they're waking up frequently at night. So initially, when there is a tendency for breathing insufficiently or inappropriately shallow at night, the body will say, hey, wake up, breathe, and momentarily cause the individual to wake up, take a few deep breaths, and go back to sleep. But when the process occurs repeatedly through the night, we call it sleep fragmentation. And as a result of that, people tend to wake up relatively unrestored in the morning or unrested in the morning. And that contributes to daytime fatigue, some irritability in the morning when they wake up, and kind of taking a while to wake up, as they say. Yes, I'm awake, but I want to lay in bed until I'm fully awake to get out of bed. The goals would be to really provide the symptom relief, to optimize gas exchange, certainly to reduce the work of breathing. What do I mean by that? Well, people tend to breathe insufficiently in sleep. They tend to breathe faster. For people who tend to have more snoring or sleep apnea on top of their insufficiencies, they tend to wake up more frequently. They tend to burn calories more through the night as well. And all of that leads to additional weight loss. And that makes it harder for them to even stay well even when they're sick. So it certainly is to avoid intubation, especially if someone has an acute illness and has to momentarily be admitted to the hospital. Certainly can remove the need for tracheostomies, as we have seen in the Duchenne world. And certainly, as I mentioned, increases sleep quality, has been proven to impact daytime functioning and quality of life as well. The type of support, I'm really going to limit my discussion on that, but our goals in the type of support is really to optimize the depth of breathing. And so what I want to just explain to you here is this is kind of a tracing of what your normal breathing theme would be. But what happens when people breathe insufficiently or inadequately is they start breathing shallower and faster. If you think about it, if I had a very tight jacket around you, you would breathe shallower and faster because it's energy inefficient for the body to keep trying to displace that resistance, that band on your chest. So the same thing's going to happen in sleep. And in dream sleep, when we lose muscle tone, this gets very, very accentuated. So the goals would be to try and normalize this breath. And so what we try to tell families is we try to use 2 levels of support. That's why it's called bi-level positive airway pressure, or positive because it's being driven into you from a machine, and it's airway pressure. The lower pressure is meant to act like a pneumatic stent. It keeps the airway open. And that's important for, especially important for people who have a predisposition to collapse their airways. All of us have something called a critical airway pressure, which means if I produce a negative enough suction pressure on you, I'll collapse your airway. It ranges from someone who's very lean and fit and young to which may be a relatively more positive pressure, means you require a fair amount of pressure to squeeze that airway shut, to someone who may be much weaker that doesn't require much airway, negative pressure to collapse that airway, and may have much lower threshold to collapsing that airway if I suck hard enough, like with a cough assist. So that lower pressure is really important in just stenting that airway open so that someone can breathe through that more effectively. The second pressure is to give depth to how deeply you breathe. And that's called the inspiratory positive airway pressure. So we support exhalation and we support inspiration. And that's why we say there are 2 levels of pressure or bi-level. Now this can be delivered with a ventilator. It can, in different modes, it can be delivered by a BiPAP machine. But for all intents and purposes, what I tell families is we are providing mechanical ventilation. And for physicians, this is important to know because our documentation needs to state the words ventilation and ventilator so that there's no fallback, no fighting back insurance companies who say you need to show me sleep apnea before I can prescribe you, or you have to show me failure of CPAP before I can give you a BiPAP machine. And so we're not often treating sleep apnea, we're trying to normalize ventilation. And so when we say we're trying to normalize ventilation, I say we are providing mechanical ventilation. And that generally removes that fight from insurance companies. I want to hand over to Rob Graham, to discuss further the ICU management related to this. Thank you.
All right. Well, first of all, I'm usually the guy you don't want to see. So I am a pediatric ICU doc, but actually have really become part of the neuromuscular community overall because of the other work that I do. So I run a home ventilator program and literally drive around New England seeing kids, young adults, older adults who have chronic respiratory failure. So managing people and helping them sort of navigate their respiratory failure at home and doing a lot of their care coordination. So it's in that context that I'm going to try and speak to you about how do you avoid seeing me in my ICU capacity and seeing my colleagues. A couple of disclosures. I do work, I've done a lot of work with spinal muscular atrophy, myotubular myopathy, and some of the other congenital muscular dystrophies. 10 minutes or less. I want to talk about emergencies that you probably have experienced and that you may experience going forward. And actually, I think it'll be helpful as a group if afterwards we have discussions and you can probably share some of those experiences. I want to talk about some practical things when you're encountering me or my colleagues around the country and think about both scheduled things as well as the unscheduled issues that come up. And as I said, sharing experiences. So I'm originally from Alaska, not from Boston. You probably can tell from my accent that I'm not from Boston originally. That's me chipping off some ice to keep our fish cold during the summer. It's illustrative of the fact that I'm not a terribly smart guy because 90% of the iceberg is under me and they do flip over. But I think it's actually illustrative also of what we know about respiratory failure and what we can do about it. And then actually, as Hank and Hemant were talking about, what we see is not representative of respiratory failure. So if your oxygen levels are low, that's the tip of the iceberg. It's everything else that's happening that's leading up to that that's the problem. And so it's one of the things as you're thinking about when do I want to initiate respiratory support when I'm healthy, what is it that we're looking for? And that's something that unfortunately you kind of have to, it's a person by person evaluation. As you know, CMD is not one thing, and everybody's a little different. And we actually don't have any standards yet. That's something that I think we're trying to work on as a group and trying to learn from other muscular dystrophies, other muscular atrophies, and things like that. But it is something that it is challenging, and it really depends on who you're working with, your age, the adults versus kids, very different standards, and it really depends on who you land with. As an ICU doc, though, you may wonder, if you run into ICU docs, it's sort of antithetical to an ICU doc to want to do chronic respiratory support. But from my perspective, I care for a lot of people, young adults, little kids and otherwise, who have chronic respiratory needs. This is a nice study out of New York many years ago now, looking at someone who, what's the risk of a child winding up in an ICU during the course of a year. So if you're previously healthy, you are sort of the standard. But if you have a chronic condition, you have a 3.3 greater risk, 3.3 relative risk of being in an ICU during the course of a year. And if you're technology assisted, you have a 373 times greater relative risk of being in an ICU. So I tell families, especially newly diagnosed people, is that you're probably going to see us at some point. Whether it's a scheduled thing or unscheduled, you're probably going to see us. And so I try and prepare them for that. Lots of other studies looking at that. Patients with a new tracheostomy average 3.8 readmissions over a course of 5 years. Some are a lot more, up to 44. Clearly something's not right there. Again, coming in and out of the hospital, you wind up with technological complications and other things. So there are some studies that suggest that, yeah, you are going to wind up in the hospital, and we need to help you through that. This I borrowed from one of the families that I work with, and the mom wears this on t-shirts and hats, and I'm not advertising for her, but if you go to Zazzle, you can get them. And I've told her she can substitute MD for RT, RN, PT, OT, you name it. She kind of does it all, and as I'm sure all of you know. And it's meant to be a little provocative to the hospital providers to say, look, I know what I'm talking about. You need to use me. But for me, it's also, it illustrates the fact that when she gets into the hospital, she is not allowed to do the stuff that she does when she's at home. And that can be really, A, difficult for her emotionally, and B, probably to the detriment of her child, because she does know a lot about what it is. So do it yourself. I think, actually, there's some stories this morning I think we heard, is that if you have a hammer, everything looks like a nail. And so if you've taken care of one patient with muscular dystrophy, you've taken care of them all. That's what you're going to hear from providers. And I think part of your job is to show them that not every nail is the same, and by the way, perhaps I'm not a nail. And so as we sort of move along, family-centered care is a mixed blessing. You need to tell people, you need to educate providers about your condition, but also your specific family needs. Now, it's a challenge because that's mixed with the fact that when you get into the hospital, you may be working just as hard to do that as you are at home. And so it's not really a respite when you wind up in the hospital, and I'm sure many of you can speak to that. Use your pediatrician as a resource. Identify someone locally. But also recognize that your pediatricians are going to have, or internal medicine for the adults, are going to have sort of limitations in terms of what they can provide in the office. And so sort of coupling with the hospital and your local providers can be really helpful. Passports, emergency information forms, POLST or MOST, medical orders for life-sustaining therapies. It's helpful to have these. Everyone has a little bit of different. Some have thumb drives with their medical histories on it. Some have notebooks. You name it. It's helpful to have something. At the bare minimum, have your emergency contact information. Because the key is you want to be prepared. If you're traveling from anywhere else in the country and you're coming to the CMD meeting in Washington, D.C., and you have an emergency, if you go to one of the local hospitals, A, they're not going to know necessarily much about CMD, and they're not going to know you. I was actually, the last time I was in DC, I was here for the SMA meetings, and one of my patients drove down from Boston, and her parents and I learned that she had a peanut allergy. We learned that because she went to one of the little events, and she anaphylaxed, and we were going to Children's National here, not realizing that. And so it was helpful that I got to go with her to the hospital and explain to the ER docs. That's not going to happen most of the time. It's kind of fortuitous, but nevertheless, it's something to sort of remember. Have something with you. Local and regional facilities, it's always different. As I said, I sort of cover New England. Now, not every hospital in New England is created equal. Some are going to be more confident and have greater capacity than others. It's helpful to know who's around you. The distances are significant. And in some respects, I would rather be at a facility where they say, you know what, I don't know. Because if you get the cowboy who says, done this a million times, that may be detrimental. So they should be asking questions of you, because I can guarantee they haven't taken care of dozens of patients with CMD. Pediatric transport teams, specialist transport teams, think about that. If you've got a hospital that you go to for most of your care, they may have a team that can go out and get you if you're at a regional hospital. So if you're someplace rural, you go where you can locally and transfer into a bigger center, and you can request that. And I think it's sometimes helpful. You need to speak up. It's in your sort of best interest to say something's not right. Contingency plans when you're away from home. All of you have probably done that to get here. Do you need a backup battery? Do you need an extra suction machine? Do you need, extra sunscreen? Think about the fluid. I mean, the weather, it's hot and humid, not that any of us have been outside today, but do you need to think about extra fluids and things like that? This also comes down to things as simple as air travel. So I'm writing letters all the time for our families going to the airport so they can get through TSA, and they can also get through baggage without paying extra baggage for all of the extra medical equipment that they carry with them. Advanced directives and healthcare proxies is not something anyone ever likes to talk about, but if you're an adult and we get admitted to the hospital, you have to have one of these. They're going to ask you about it, but I think it's also good to anticipate and plan ahead for these. Is that this is good for sort of discussing, what is it that I want in an emergency, and what is it that I want sort of routinely. And for those who are turning 18 in this group, start that process soon. Because your parents can't necessarily speak for you once you turn 18. You need to designate someone, and it could be them.
Can I ask a question?
Oh, please.
So it's just a quick question in regards to medical alert.
Yeah.
We're from Canada, so I don't know if it's the same for the United States, but she wears a medical alert that has a very unique number of points
right. Yeah, did everybody catch that? So there's the medical alert bracelet, and there are other sort of things that are similar. They should, but they may or may not. There is no uniform system. Our 3 hospitals are on completely different computer systems, and by the way, providers don't talk to each other. Someone asked yesterday, oh, is there a children's hospital network? No. I mean, there are collaborative efforts, but we don't talk to each other on a routine basis. So yeah, I mean, ideally, yes, that would be that we'd have some sort of identifier and some sort of common, there's lots of platforms people are exploring, but nothing that works at this point. And you may, as I said, one of the best things you may have is strictly your provider's business card and just say, please call this person, honestly. I think this, for those who are old enough to know the song, you can check out, but you can never leave. That may be sort of the experience that you have once you're in the hospital. ED and ICU care plans. If you have a facility that you go to frequently, give them your information. What is it that you want done? I actually tell people to do this the same with their local police or fire department and their first responders, is to say, hey, by the way, we're in your neighborhood, so when I call 911, this is me, or this is my kid, this is what I need, and I think it's actually really helpful to do that preemptively. Respiratory issues is a primary or secondary thing. If you're coming in for something completely unrelated to respiratory needs, you need to emphasize that you have a respiratory problem. Because if that gets overlooked, you may start a sort of downward spiral. Oh, I'm coming in because I have a broken leg. Well, you can't neglect the breathing things just because you have a broken leg, because actually there are lots of other issues that may then evolve. And so I think it's helpful to sort of remind people that, oh, I'm in for something completely unrelated, but I've got other needs. Bring your equipment, bring your protocols. For those who use BiPAP, as you know, that mask is your mask, and most hospitals aren't going to stock whatever it is that you use. They'll have a couple, maybe, and it's always a challenge, and don't hand it over to anybody because they may just throw it away. Helpful to remember. Direct admissions, I do this a lot for the families that I work with. I will try and arrange a way to bypass the ED because things seem to go wrong in an ED. Part of it is we talk about ED docs and ICU docs. We like to do things, like to poke needles into things. We like to do all sorts of other stuff. But if you can bypass that, it may save you time, it may save you exposures, and you can actually sort of facilitate the care. Now, that's not going to be possible many places, but something to sort of ask your providers about. The key, honestly, as I said, is to reach out. If you're having a problem, or even if you're not having a problem, is you're calling Hank, you're calling Hemant, you're calling me, you're calling whomever is the sort of driver with you of your team. Triage process, every hospital is a little different in terms of where you can be cared for. It depends on how much technology support you have, how sick you are. If you're not comfortable where you're at, you can be asked to be moved to a different location. I want to be someplace where there's a monitor or otherwise. Don't feel though, one of the things that we've looked at is, at my hospital, if you're on BiPAP or certainly if you have a trach event, it doesn't matter if you're in for just a hangnail, you're in the ICU. That's not necessarily appropriate for a number of reasons, but it is something to sort of recognize, and it's one of the reasons why it can be challenging as a family to sort of navigate that. Calibrate the providers to you. Bring pictures. Seriously, bring pictures of what you are like normally. And it's helpful because when you're laying there in the bed and you've already got a muscular dystrophy and you're not moving much and then you're sick, you don't look like yourself. None of us do when we're sick, and it's helpful to sort of point out to people that, yeah, by the way, last month I was driving around Washington, D.C. and having a great time. Let's see. So, as I said, that's me, grew up in Alaska. You're not a red herring, but you will feel like you're swimming upstream, and I think it is an effort, and I think that's part of the challenge, something to think about. A couple of things I do want to talk about, though, as we go forward. So, a bit of a misnomer, conscious sedation. This is something that any of us are at risk for, and those who are hypoventilating, if they're hypoventilating at night, and certainly if you're hypoventilating during the day, this is a problem. Conscious sedation you can sort of think of as, I'm a little bit pregnant. You are sedated. Maybe you're sedated a little bit more deeply, but maybe you're 2 months along or you're 9 months along. But what you have to realize is that sedation is just that. It's an altered level of consciousness, and it's going to potentiate the changes in your breathing that Hank and Hemant were talking about. And so I think it's helpful to realize this. If it's for wisdom teeth, if it's for setting a broken bone, if whatever it's for, you are not necessarily conscious, and so you have to put that respiratory monitoring and the respiratory support first before you get anything. And that may be, the standard is if I went in, or actually when I had my wisdom teeth out, they check they give me a little bit of laughing gas, they put on a pulse ox to check my oxygen. That's missing what's underneath the iceberg. That's the CO2, and you need to put on a CO2 monitor, the transcutaneous or an end-tidal or something, because it's when you start to hypoventilate more, then you have a problem. Consider different options for ventilator support. BiPAP can be used in the operating room or in a procedure room or something like that. You have to work with your providers. Regional anesthetics, so epidurals, blocks, pain treatment service can be really helpful if you're having something done. It helps you get away with less systemic medications, but it can also be very effective and something to think about. Echocardiograms came up in some of our discussions yesterday. CMD is not one thing, and so some of you may have cardiac problems, a lot of you may not. I can tell you that your providers aren't going to know unless they start to sort of investigate themselves. And so work with them. Do you need an echo? Do you need an EKG? Do you need a Holter monitor or something like that before you have a scheduled procedure, or just as part of your routine stuff? If you're intubated for a procedure or you're intubated for a pneumonia, the question always comes up, when do you extubate? That is somewhat subjective. We have some protocols that we extrapolate from other conditions. But I think the key is you've got to have contingencies. You've got to have the BiPAP there. You've got to recognize that oxygen amongst the neuromuscular community is seen as the enemy. It's not necessarily the enemy. It's a good thing to have. You want to keep your oxygen levels up. But as I say, heed the warning. Because what it's doing is, again, it's the tip of the iceberg. If your oxygen levels are low, you're missing that hypoventilation, that CO2 problem, the lung collapse or lung consolidation. And so you want to use pressure, not just oxygen. And as Hank talked about, aggressive airway clearance, pain control is something that intensive care providers and sometimes ER docs are a little wary of in patients with muscular dystrophy. Because if you give them morphine, they're going to stop breathing. Well, if you give anybody enough morphine, they're going to stop breathing. But I also try and tell people, if you're in pain, you're not going to breathe well either. So looking at alternative things, Toradol, IV Tylenol, low-dose morphine, you can always start low and work your way up, is sort of what I try and emphasize. And then other things that would get behind in the hospitals, nutrition and bowel regimens. We've got to keep our calories up. People who have muscle problems at the beginning, oftentimes if they get behind on their calories, get weaker. And so it's helpful to do that. And then bowel regimens. If you are FOS and it's pushing up, you can't breathe as efficiently either. I'll run through a couple of other quick things. So parent presence in the ER and in the OR. There is some allowance during procedures, and whether it's a spouse or a child or otherwise, you can ask. Oftentimes, hospitals will have their own policies. Can you go back to the operating room and help at induction? Can you be there during a procedure? It varies depending on obviously what it is, but sometimes it can be helpful if you can be there and otherwise and look at those options. Resuscitation in the OR, as I said, be explicit. What do you want done? Do you want the breathing tube put in if something goes wrong? What happens if there is a heart problem? You want to anticipate this stuff up front. Assessing distress. This can be challenging in someone who's got muscular dystrophy. Most of the time, if I'm having a problem, I'm going to breathe deeper and I'm going to look distressed. But if you don't have that capacity at baseline, maybe you'll breathe a little faster, but it's not necessarily going to be deeper. And so you have to sort of remind people to say, point out, yeah, that numbers, you have to sort of look at other markers, not just how are you looking. Because if you can't breathe faster and deeper at baseline, it's going to be worse when you're having a problem. And I think it's sort of wrap up some of this. The transitions in care, adult hospitals, for those of you who are at adult hospitals, It's not the same as being at a pediatric institution. Now, we will take care of people of all ages at Children's in Boston, and you can actually have an operation with us as long as you're under 35. But it is a challenge. These transitions are difficult. The type of care and the sort of personalized care is less coordinated and maybe not as warm and fuzzy at some of the adult hospitals. We try and help in those transitions, and it can be challenging, but start that process early is sort of what I recommend. I sort of have the bias in terms of what I do. I think as an acute care provider, I want to extend my services out to help you transition home and prevent you from coming into the hospital. There are a few of us around the country that do that, and then from other disciplines as well. You know, but it's funny, even at my own institution, I'm having to be you know, a squeaky wheel when I'm talking to my colleagues about kids with chronic needs or young adults with chronic needs, is that we don't get it. And I think that's probably what you guys can speak to. So hopefully we've been able to cover a lot of that. I think we want to leave time for questions and open discussion and otherwise, and we can sort of field it.
So we just got a request to talk a little bit about the hyperinflation study that I guess we owe you the results to. So for those of you that weren't aware, this was a study that took place at Philadelphia and Cincinnati Children's and was funded by the NIH with significant contribution from Cure CMD. The study involved subjecting children in a randomized manner to a treatment or control arm, where the treatment arm was subjected to hyperinflation therapy by measuring the appropriate and the higher amount of the highest, safest pressure we could get to for over a period of a year. And so, to cut a long story short, after a year, the average adherence to a 30-minute regimen twice a day was about 44%. So we recognize that it is hard for families to commit to a treatment regimen that requires sitting down, doing manual inflations twice a day for 30 minutes each, and to do that for a full year. We also recognize that few people were able to tell us clearly what the problems were in being able to do it on a regular basis. And we totally understand that life happens and you get busy and you have other responsibilities. But I think getting some information from you guys as to what really could work better in the longer run would be really helpful. In terms of a benefit, there was a demonstrable immediate benefit to hyperinflation therapy, and this has actually been supported by previously existing literature. So doing the lung capacity measurements in the morning and then being subject to hyperinflation therapy yielded significantly better readings of lung capacities in the afternoon. So that speaks of some benefit that certainly persists for a period of time, for a few hours. Again, going back a few decades, there was a similar paper with 6 adults or 7 adults that actually demonstrated a sustained benefit up to 2.5 to 3 hours after hyperinflation therapy. So what happened over a year? I think at the second visit, we saw our peak impact of the therapy, with a lot of people being very adherent to therapy then, and with adherence rates of almost 80% at the second visit. And so we had a significant improvement at that point, although it was not the effect that we had desired. But it gradually petered off towards the end of the study, where it was almost equivalent to where they started. And we feel that there's a combination of things that play into this. One is, of course, the adherence. It was highest at the beginning and lowest towards the end of the study. But the other aspect is that there's clearly some sense that people who have a little milder degree of restriction are going to be much better responders to hyperinflation therapy. And those who tend to be much tighter are probably going to require higher pressures and will need higher intensity of therapy, certainly beginning or maybe sustained for a period of time in order to really see that impact. And I think that was pretty much it, what we found for the study. I think we'd like to open this up to questions going forward.
What is being done, if anything, at this point? You guys already know about the pulmonary conditions of these people here who have.
I don't know why we can't get them a lapel mic.
What is being done to educate doctors as a whole? One of the things that we ran into is that doctors that were dealing with Angela almost in the dark about some of these issues. Is there a way to with the specialists like you guys are able to communicate with the community, to the medical community as a whole?
Actually, sort of, when you think about congenital muscular dystrophy, when we went through medical when the three of us went through medical school, it was probably a paragraph about that big.
Smaller.
Yeah, okay. May have been a sentence and a half. So yeah, this is one of the challenges that actually you face and I think we face. And to be perfectly honest, I think that's going to be one of the major objectives of Cure CMD is to educate. And you'll see this actually, obviously, yes, the MDA has probably the biggest impact, but it doesn't, on a condition-specific basis, it's not necessarily that helpful. It is hard, and we struggle with this because if you offer a lecture, you're only going to get those who come, and oftentimes those are who are interested. And if you're offering an online educational course, again, they've got to have some interest in it. And unfortunately, it often is just driven by a case by case. They're going to land with a family, and then they're going to educate them or seek some education. Unfortunately, you're charged with educating the medical community.
I think part of the problem is that there's a very proud and small community of both neurologists, neuromuscular specialists, and pulmonologists with interest. And I think that's probably twofold. And I think one of the issues is that for many years, I think neuromuscular disease and clinical management wasn't seen as particularly exciting or sexy. There weren't many advancements, there weren't new drugs, and so I think a lot of people just kind of hoped that somebody else would go ahead and do the work. However, I will tell you at the most recent American Thoracic Society conference, which is the big meeting for pulmonologists, there were two presentations that generated a lot of interest. One was related to a medicine called Spinraza and SMA, which has been shown to be very, very effective. And then another one was for something called Exondys 51, which is for a specific type of Duchenne muscular dystrophy and had also very positive outcomes. And the interest was that people, I think, realized that now there are actually therapies for some, not all, but some neuromuscular diseases. And in an organizing meeting for the next conference, there's a lot of interest in trying to broaden the discussion. And so I took that as a very favorable outcome, and that now there will hopefully be more people with interest. And there certainly will be a number of us with interest in trying to, be the Pied Piper and, spreading the gospel and, being a resource. But I think now I'm really hopeful that there'll be more people acknowledging that it's a, population that has obviously a tremendous amount of value and a lot of potential interest, and I could consider, a nice clinical challenge in managing.
To be more specific, to answer your question also about what we are doing, we have trainees, and we all recognize that we can't often change the minds and the attitudes of the people existing in the field, but we can certainly influence those who have yet to reach the field. And we are encouraging, I think it's amazing that we actually have this exposure at our institutes of that have the strength of neuromuscular core support. And having that influences our fellows to think differently. So as they leave our training institutes and wherever they go, they will continue to think about these things. This has already begun to happen in the last few years, and we are connecting some of our fellows who've left our institute to Reagan and Carson in the area. So at least I think it's time we probably make a directory of people in the field. We've got Salt Lake City, Stanford, all these major cities covered, so at least patients have areas that they can go to. There are certain areas that are certainly more difficult to get to. I think it's just a matter of time. The other thing is certain companies like Centera has actually taken some ownership in broadening and supporting education ventures and supporting the education of the community. There was at the ATS meeting, we were a part of one of those events, and it was, it had fairly decent attendance. The other aspect is we've submitted proposals for full postgrad courses that include the beginning to the end of this for the American Thoracic Society meeting next year. And Dr. Mayer has also submitted a proposal to the MDA for the next clinical MDA meeting. So I think we're looking at targeting these venues almost every other year so that we can capture almost every crop of fellows that goes through the training program and hopefully begin to sway things somewhat differently. Is a question? Here's the mic.
Hello. As far as the ventilation, what do parents need to be looking for when it's time to maybe start doing the BiPAP? Is it the sleep study? Because that's what I would think. But sometimes our kids have even though it's an 18-channel sleep study, it comes back normal, but it still probably needs to be pushed on to these pulmonologists. And then after the BiPAP, you're on the BiPAP, what is the next step that those parents need to be looking for, signs that maybe, moving to the SIP ventilation or different things like that?
Really good questions. Thank you. When we see our patients very frequently, I often tell families, as long as I'm seeing them frequently, it's hard for you to tell me I see this specific change. That I see this specific change. And it's when we see them periodically that we can pick up things. At our center, we are fairly aggressive, and any new diagnosis, especially if it's a CMD, I have a lower threshold to study. Certainly, if the vital capacity is under 50 to 60%, I recommend a sleep study. There was a recent publication that actually supported such an effort because patients with col-6 tend to actually drop vital capacity almost 20% when they go from an upright to a recumbent position. So if you hit 40% when you're laying down, there's a possibility, especially if the change is dramatic, that you can have hypoventilation. So I have a low threshold, and I always say we need to reassess. The second thing is I always, I guess when we look at children, we always look at the kinematics or the movements of the chest and the abdomen. And so clinically, we're looking for subtle indicators, even with maximal effort. If we don't see much chest movement clinically when someone is sitting upright and awake, there's a good chance it's much more reduced when they are laying down. So those are subtle indicators for us as to when we get sleep studies. And then, of course, there's the issue of being tired, fatigued, or having changes in lung function over the preceding 6 to 12 months. When you have a doubt, one of the things I recognize is that when people talk about a normal sleep study with saturations of 98, 99%, I feel a little better then. And this is having learned this from the Duchenne world and from a few of our CMD patients, that if the saturations are 96 to 97% on average, there's clearly something off. And this is why just an overnight oximetry study is useless for home studies. And so the carbon dioxide monitoring is really important. And when in doubt, we will get a capillary or morning blood gas from the fingertip just to make sure that the readings we had overnight were appropriate. So that's something I almost always order because I never know what to expect when I'm sending somebody to a sleep lab. And so if someone's breathing really fast, they're not going to give a good reading of the carbon dioxide level. And so I always recommend getting one in the morning right after the sleep study so I can corroborate those two. When lab work is done routinely, one of the things that people look at when they measure the renal panel or the kidney panel is the serum bicarbonate level. And so whenever those are over 28, 29, I get a little suspicious for our children. So those are, again, indicators for us. As to when they need to transition from just nighttime ventilation to adding SIP ventilation a day, when we see our patients, we tend to look at their carbon dioxide levels and their breathing rate when they're awake. So if someone's breathing 16 or 18 a minute, looks comfortable, has no problem speaking, and their carbon dioxide levels are in their mid-40s, that's fine. But if someone's breathing 28 a minute and is still in the mid-40s, to me that's compensating. They're breathing really fast, and so that's somebody I would offer that to, because you need to conserve calories. You can't expend it and then be that exhausted. So those are some of the things we look at. So the need for daytime ventilation largely becomes more influenced by how we view the children when we are in clinic. Some of these things are very difficult to put stops on to say, if you see this and this and this, then you need to do it. Because sometimes there's a subjective component to this. If someone gets a cold, their borderline status may become frankly abnormal. So we have to try and anticipate that variability. And there's a little bit of skill, I guess, to some of that. But there are some clear markers that we can see that will tell us, okay, I think it's time to consider that.
Yeah, I think all of us actually on the sort of proactive, we'd probably do it before others might. You know, does putting someone on BiPAP actually help keep that chest wall expanded so you don't get as much restriction over time? My approach in general is I don't want to wait for you to have that pneumonia, and I don't want to wait for you to have that bad sleep study, because as I said, the horse is out of the barn. You're all, you know, you want to be as proactive as possible. I think we heard this morning, doing that on a 3-year-old can be a little challenging. And so from a practical standpoint, I often will say, let's order it. I sort of advocate with the insurance companies and say, we know with this condition that whether something's abnormal now, or they have an abnormal bicarb or a sleep study, we know they're going to need it, and try and just desensitize them to it. So to get the 3-year-old maybe to wear it while they're watching a cartoon or you're reading a book to them or something like that, get them to wear it during the day and integrate that in. Because the last thing you want to do, and I actually had a young lady admitted to the hospital with SMA last night, they hadn't used it. And then to use it during an emergency is not going to work. So it's better to sort of have a low threshold and sort of get used to it. And as I said, you know, also, as we're sort of thinking about all the new therapies coming up, the gene-targeted therapies and otherwise, you want to be as healthy as possible to get potential benefit from those when they do come online. And so, in that respect, being proactive is to your benefit long-term.
I'll just add one comment and, you know, point out what probably is the obvious fact that you don't go one day from being perfectly fine to being in respiratory failure. There's a continuum, and Hemant was, you know, talking about, you know, you go from a stage of breathing perfectly normally and oxygenating and removing carbon dioxide well, to not breathing properly and still being able to remove carbon dioxide and bring in oxygen, to then breathing poorly and not being able to ventilate and oxygenate. And you know, so what you as parents can certainly do is, I gather none of you watch your children sleep at night, but if you choose to do that, I encourage you to every once in a while. If you look at them breathing and just something's not quite right, they're asleep, but they're not really sleeping comfortably. You know, that may be a first sign that something's beginning. Again, obviously you don't want to wait until you get to the point where you end up getting a sleep study and the CO2 is 70 or 80. But you know, sometimes it takes, you know, just a parental instinct and then having a receptive physician, which I guess admittedly is a bit of a challenge, and then, you know, pushing the issue a bit.
So before we end, we just have a couple of online questions here. The first is about higher span BiPAP for CMDs, on whether or not you particularly recommend this.
Well, I think that's probably coming from some of the work of a guy named John Bach, who feels very strongly that the bigger the pressure change is between the low number, which is the expiratory pressure, and the high number is important. I happen to disagree strongly. When you use a ventilator, you use it to breathe, and you don't get any added benefit in breathing more deeply than you need to. The whole purpose is to be able to take a breath and bring in oxygen and remove carbon dioxide. And to me, the idea of breathing above that makes really little, if any, sense. And the issue is that if you actually remove too much carbon dioxide, then you can run into problems. And the way that the system works is that when blood flows through your lungs and the hemoglobin grabs onto oxygen, to remove it in the muscles and all of the organs, the carbon dioxide level and the acid level need to be at a certain point. And if the carbon dioxide level is too low, hemoglobin is going to hold on to oxygen a little bit more.
The one caveat I have to that is daytime can sometimes be a little different. I definitely have some people, whether they're using continuous BiPAP or if they're using a trach and event, is they actually want a higher level of support during the day because you can talk louder. And so you're compensating for a leak. So you're actually not, you don't run into the problems that Hank's talking about because that extra size breath is actually just coming out, so you're louder. But in general, yeah, I'm not sure that any of us would.
You know, from a clinical point of view, I also feel the challenge gets to be how do you get somebody comfortable with such high pressures? And with higher pressures, the mask has to be strapped on tighter because your leak increases. And as you increase your pressures, your leak begins to increase, and it doesn't become more comfortable.
Thank you. And then last question. My son had aspiration pneumonia in 2014 as a result of dysphagia. Going forward, what are some of the signs to be mindful of to look for future aspiration signs? He's on puree food and thickened drinks.
Yeah, so this is very much falls in the personal choice question because aspiration is a huge problem. And the thing to remember is that people with CMD have normal lungs to start with. It's a neuromuscular problem. You're going to a pulmonologist whose specialty is lungs, but it's not a primary lung disease in that sense. It's a ventilation, it's an oxygenation problem. Aspiration, though, will give you chronic lung disease over time. I have some families and some young adults who, we take a lot of pleasure out of eating. Hence the lines out there today. This is what we do. And as a family, it's actually nice to sit down and have a meal. And so honestly, I view it as this is again stylistic, it's a personal choice do you get a swallow study or not? And do you abide by the findings or not? It really is personal. There's a risk if you know that you're aspirating and you don't necessarily need the swallow study you probably know. But I think you're just assuming a degree of risk for that. And the more, it is a cumulative toll. The airways get inflamed, you have more asthma-like symptoms, and you're gonna be more prone to pneumonias. And so I think it's a risk. But again, it's very much a personal choice because it's, participating in a family meal and just the pleasure of eating is something that's can't be downplayed.
I don't really have anything else to add.
Yeah.
Yes.
Rachel's cutting us off, actually.
Question over.
I was going to say, are there any technological improvements coming in sleep studies that make them a bit more bearable?
So we can make the parent couch more comfortable. We'll give you a heavier blanket. We'll get a board for you. It is what it is. It's a test. And they are portable ways of studying the children in their own home environments. The problem is that it's the current recommendations for a portable or a home study require individuals to have no major comorbidities. So it's fine for an adult with standard snoring sleep apnea, but not yet cleared as a safe thing to do for a home sleep study with an individual, whether it's adult or pediatric, with a significant neuromuscular disorder. So if I were to get a report today that was done at home with data missing because of movement artifact and nobody was there to put the lead back on, I'd be very reluctant to put my name at the bottom of that and sign off of that as normal, knowing that the diagnosis underneath was SMA, or was an older Duchenne individual, or an adult with ALS, or somebody with CMD who is 8, 9, 10 years of age. I'd be a little nervous about that. And that's just from being a good human being and trying to be careful.
How frequently should we get sleep studies? Right now, our pulmonologist has us doing it annually, and we're titrating up every single year. So
For the nasal mask ventilation?
We have BiPAP.
You do.
Yeah,
So I don't often do it every year. How often should children be subject to titration sleep studies where we retitrate our bilevel pressures? Again, it's a stylistic approach. I bear in mind the cost of medicine today, and I do the studies beginning. Once I know it's a good quality study where someone has been titrated well, our sleep lab, we have invested time and trained our technicians on how to do neuromuscular studies. And we give them detailed instructions on how to titrate these individuals. It's different from somebody who has just straight sleep apnea. So knowing the quality of the study at the end of the titration and looking at the tracings, I can feel comfortable not needing to do this in a year, even unless somebody has had significant weight gain, or their body habitus has changed in a certain manner, or their scoliosis has really progressed and they're going for scoliosis surgery. That may be an indication. If the goals are just to do this, just to increase pressures, I usually get a BiPAP download, and I look and see what's been going on, what the adherence is. And if I see some instability there, I might actually act on that and go forward, see how the next 6 months go. So at the earliest, I tend to go 18 to 24 months before I bring somebody back into the sleep lab, sometimes even longer. So that's just a style thing, because I feel comfortable being sleep trained as well for making some, sorry?
But we still have to titrate up every time, though. Like their carbon dioxide levels are still high with the current settings. I mean, there's reasons why they're titrating up. So if I were to allow that to go a whole other year, if I did go every 2 years versus every 1 year, because I can see the change in them.
So that's an interesting point. I guess it then starts as to what level have they been titrated to. If somebody just titrated a child up to a certain level and left a margin of, some elevated carbon dioxide levels, we tend to overcorrect a little bit up front so that we don't have these issues. So our targets are 40 to 45 is my highest range. I like to keep people underneath that. It certainly improves daytime functioning. I guess that's it. Thank you very, very much.